be breaking away from the Olympics and joining us in a few minutes. Welcome to our fourth, I think, Lupus Health Conference of 2024. I'm Lori Day. I'm the Communications Director of the LFNC. I've worked for the Lupus Foundation of Northern California for about 5 years, and we're excited to welcome each and every one of you today. We have an exciting conference for you planned. Today we'll hear from 2 pharmacists who will discuss lupus medications current and future, and then we'll open it up to questions. So now I'm excited to introduce our speakers, Dr. Benjamin Hinton and Dr. Osa Edogun.
Awesome.
Dr. Hinton is a senior market access and analyst and community pharmacist. He graduated from Hampton University School of Pharmacy. Benjamin has a passion for making an impact on the community at large. Ever since his tenure at HU, he's been actively involved with improving patient access, and particularly in underserved communities. He aims to increase diversity in pharma with a focus on patient care, healthcare innovation, and creating new value through integrated data sets. Dr. Edogun is a clinical pharmacist and a graduate of University of Washington School of Pharmacy. Osa developed his passion for working with patient populations with more rare and chronic disease states such as cancer, HIV, multiple sclerosis, psoriasis, arthritis, and solid organ transplant during his 3 years of working in specialty pharmacy. Understanding and helping patients navigate complex medical conditions, drug regimes, side effects, and drug interactions has been a foundational part of his professional practice as a pharmacist. His leadership and professional experience focus on patient care and technology innovations that enhance the patient pharmacy experience. Before we begin, remember you can ask questions at any time during the presentation. You just have to type them into your Q&A section or on your chat. And we will ask all of the questions at the end during a Q&A session. And be sure to make use of this great opportunity to not talk to just one pharmacist, but 2 for all of your questions, okay? So now welcome Dr. Hinton and Dr. Edogun.
Awesome. Thank you so much for that wonderful introduction.
Yes.
First thing we're going to go over is just the agenda for today, as you already did, the wonderful introductions. We're going to go overview the presentations. We're going to go over how lupus is treated and go over some recent FDA-approved therapies more in detail than the last presentation. We will go over therapies coming to the market soon that are going to be exciting, and as well go over some of the important things to go over about clinical trials and how you can get started in participating in them. We will then move forward to do the question and answer discussion. And then after that, we'll go over some LFNC resources and events.
Sounds good.
Important to note here, any protected health information provided in this presentations with the pharmacist will be protected by the pharmacist as directed in the HIPAA privacy laws. Any information shared during the open Q&A session of the presentation will be at the discretion and disclosure of the participant. Additional disclaimers: the views and findings expressed in this document, presentation, and related activities are those of the authors and do not imply endorsement or reflect the views of the Lupus Foundation of Northern California or the affiliates of the organization or entity of any member who contributed to this work. Individuals have served in their individual capacity. The information provided herein has been organized to provide the participants with as much important and integral information as possible in the time allotted. This is not a complete list of side effects and warnings. For any unexpected effects while taking these medications, please contact your doctor or pharmacist. The material contained within this presentation does not substitute it for appropriate patient-centered medication counseling. And with that, we're going to go over some recent FDA-approved indications. Ben?
All right, thank you so much, Osa, for getting this kicked off. Before we jump into the more recent FDA-approved agents for SLE, lupus nephritis, I wanted to start by saying, it's important to have these discussions with your physician. And before you start having those discussions with your physician, I would also recommend having a journal to kind of start advocating or using it to advocate for yourself. Start taking notes of like how you feel on different days, what aches and pains do you have? Sometimes it's really hard to kind of keep up with all of those symptoms that you may be running through from day-to-day life, especially, as you go through their everyday life and things get busy. What I've heard consistently sometimes that, some people battling they don't always feel heard. So when you aren't heard and you feel like your thoughts and feelings aren't being communicated and you don't have a space for you able to do so, it's harder by the physician to be understood. So at the end of the day, you know your body better than anyone. Whether it's having joint pain when you wake up, or having tasks get more challenging, only you know how your body works, and can be your biggest advocate for yourself. So and then lastly, non-pharmacological interventions such as like sun protection, smoke cessation, having a healthy, balanced diet, regular exercise, all of those things, of course, are good things to kind of work on, not necessarily having to, depend on pharmacological drugs. All right, so now we're going to hop into it. So last session, we touched on the initial drugs used to treat lupus, including like cyclosporin, Plaquenil, and more. Today, we're going to look at some of the more recently approved agents that you can discuss with your care team to see if they are right for you. Note, this will not be given necessarily in place of the other meds, but more so in combination with. Ideally, we want you to work your way to have like a stable regimen, with the goal of reducing as much as possible. But we understand sometimes when severity hits, and you get flares, you need a medication that can be given in addition to like your standard treatment. So first off is Benlysta. It is a anti-B lymphocyte stimulator. It was approved in patients with 5 years and older with active autoantibody positive systemic lupus erythematosus, and also patients 5 years and older with active lupus nephritis receiving standard therapy. So that was actually a new change in their label. They got the new update in May of this past year. As far as administration, it can be dosed either IV or sub-Q. For IV dosing, the Benlysta must be given via ID as like a loading dose based off the weight, given 10 milligrams per kg every 2 weeks over 1 hour for the first 3 doses. And then after that, you can have an IV infusion for over an hour every 4 weeks after that. Pre-medications may be given for the IV infusion just to kind of put that barrier in place and kind of reduce the risk for potential hypersensitivity reactions. And the IV infusion must be administered by a trained healthcare professional who are prepared to manage any anaphylaxis that may occur. In lupus nephritis, the sub-Q dosing is only available for adults. It's administered as 1 200 milligram injection weekly into the abdomen or the thigh. And if you're administering it in the abdomen, you kind of want to it's really like on either side of your belly button. You really kind of just want to squeeze a little bit of what you can of excess body fat that you have, and then inject it at like a 90-degree angle. And you could also inject it in your thighs as well. As I mentioned, if you're taking the Benlysta for lupus nephritis, you may have 2 injections for the first 4 doses. And then after that, it will be once a week after. You can store the auto injectors or pre-filled syringes in the refrigerator. Do not freeze or shake the solution. In SLE, the sub-Q version is available for patients 5 years and up. So that's good. It's weighing for patients that are for kids rather weighing greater than or equal to 40 kilograms. The dose is going to be 200 milligrams once weekly. And if the patient or the kid weighs between 15 to less than 40 kilograms, the dose is going to be 200 milligrams, which is 1 shot like every 2 weeks. And in adults with SLE, Benlysta is administered as a 200 milligram shot once a week. We can go to the next one. So thank you. Let's see. So as far as efficacy, one good thing about having a medication that's out on the market, that's been approved, and also the updates with technology, they're able to do a lot of real world studies now. They're able to do a lot of post-marketing studies like in actual in clinical practice. But what they found was that like at six months, over 80% of the patients reduced or had up to a 50% reduction in their steroid use, or they discontinued use over at 6 months, which is great. At 1 year, patients saw reduced disease activity, amount of flares, a decrease in disease severity, especially in African American and Hispanic patients. And then over 60% had improvement in skin, joints, and kidneys versus the standard treatment alone. And has also been studied earlier in treatment regimens to try to reduce that steroid usage for flares. And like I mentioned before, new real-world evidence studies are being performed to evaluate the treatment regimens in practice. So before, you might have to go from steroids to another immunosuppressant, and then work your way up to Benlysta as well. But now they're trying to test it out with having combo agents with Benlysta and also immunosuppressants earlier on in the treatment therapy, so that you're not really depending on the prednisone or taking prednisone for too long. So they're kind of doing studies to determine what's the best fit and what would be the best utilization of these drugs. One drug interaction to be aware of is rituximab. If you are taking rituximab, it can increase the risk of serious infections and post-IV injection systemic reactions such as like redness and things of that nature. In terms of contraindications, if you've had a previous anaphylaxis reaction with Benlysta, you should not take that again. And then for female patients, we would recommend that you avoid pregnancy during therapy and for at least 4 months after discontinuation. Let's see. And then other formal drug interactions, like they really haven't been studied with Benlysta, but they have been administered with other corticosteroids, antimalarials, and other immunomodulatory and immunosuppressive agents as well. Right. And then as far as warning, so the hypersensitivity and IV reactions, like allergic reactions, including anaphylaxis, have been reported with Benlysta, including patients that have previously were tolerated on infusions. Pre-medication definitely may mask these reactions, so clinical monitoring with a healthcare provider is recommended, especially if you're doing the IV route. Some other things to be aware of is that it can increase your risk of an infection just because it is working on the immune system. And as far as vaccines, definitely consult with your healthcare provider if you are considering getting a live vaccine, such as like yellow fever, MMR, smallpox. This is not recommended use within 30 days or during the Benlysta therapy. There is a small increased risk of cancer or other malignancies. And then another thing that I wanted to touch base on is the increased risk of psychiatric events. So if you previously have had depression, suicidal ideation, behavior, and other psychiatric events like that, that has been reported with Benlysta. So once again, I think that's why it's also important to keep a journal so that you are kind of aware of your mental processes, how you're feeling on these drugs, and we can kind of gauge, when is the best time to speak and reach out to somebody, especially in terms of like your physician. It also has an increased risk of PML, which is progressive multifocal leukoencephalopathy. And what this is essentially, it's an increased, the risk is increased with this immunosuppressant therapy or an impaired immune function. So essentially, it increases your risk of a reactivation of what's called like a polyomavirus. And it's more so specifically if you're immunocompromised. So the risk is a little bit higher if you're taking this drug for SLE. And then some things to be look out for is that it can result in death and severe disability. So, but if the main thing is if you notice any new or worsening like medical problems or memory loss, trouble thinking, dizziness, loss of balance, difficulty walking, loss of vision, then definitely reach out to your doctor so that they can evaluate you. All right, so you can go to the next slide. Thank you. All right. As far as warnings, I went over the hypersensitivity and IV reactions, as well as the increased risk of infection. And yes, I kind of went over these. All right. So these are all good. So as
All
far
right.
as, oh, these are you, right? No.
Yeah, that's me.
All right, good.
Thank you, Ben. Yeah, thank you for going over Benlysta. I think one important thing to note about Benlysta is because of its mechanism, Benlysta often takes about 3 to 6 months to become fully effective. So in patients with serious disease manifestations, Benlysta is combined with steroids or calcineurin inhibitors, and immunosuppressive medications that act faster can be helpful. So because Benlysta takes a little while to really start seeing the full effect, we do want to continue to have other drugs on board while they're on it. So really, really great coverage. Just wanted to add that. Next agent we're going to go over that was recently approved is Lupkynis. This was approved back in January 2021 and is used primarily for lupus nephritis. So Lupkynis is a calcineurin inhibitor. It's very similar to cyclosporin. It has immunosuppressive as well as anti-inflammatory effects. Calcineurin's role in your body is to activate your T cells, which are a type of immune cell. Lupkynis binds to calcineurin and inhibits it, which prevents the T cells in your body from triggering an autoimmune response. This results in like decreased inflammation in the kidneys, which does definitely preserve the kidneys for a lot longer in patients who do have lupus nephritis. It is not recommended for patients who have baseline low renal function, such as an eGFR less than 45, unless the benefits outweigh the risks. And it also is not recommended in patients who have very, very high blood pressures greater than 165/105. And that is because the medication can cause an increased risk of hypertension and can make that a little bit worse. Some hallmark results in the clinical trials for this drug include faster time to complete renal response 1 year after starting the therapy compared to the standard of treatment. Standard of treatment in this case would be mycophenolate and some low-dose steroids. So when you add Lupkynis to that standard of therapy, you do have a faster time to renal recovery and stabilization of your renal function. In addition to that, some other results came in that they also result in reduced proteinuria, so reduced protein in your urine, which is a marker for some kidney damage, faster than the standard of therapy, which is mycophenolate and steroids alone. So we're going to go over just briefly the Lupkynis phase 3 trial, which is Aurora 1. So this basically goes over the methods as well as results of the study. So this was a 142 hospital study, 27 countries involved, and was double-blinded. 357 patients came in with active lupus, and they all received the standard of therapy, which was mycophenolate and tapered steroids. As you can see on the chart, the placebo for 24 weeks, they had 20% of those patients have complete renal response. Complete renal response meaning that their eGFR, their kidney function, was maintained over 60 milliliters per minute, or no confirmed decrease greater than 20%. So their renal function stayed stable and stayed very well above what we wanted them to be while they were on the treatment. So only 20% of patients with placebo, which is just placebo plus the mycophenolate and steroids, were able to maintain that good renal function. In comparison, at 24 weeks, when you added voclosporin instead of placebo, 32% of patients were able to maintain better renal function and to maintain that very well during that 24 weeks. When we continued the study to 52 weeks, which is about a full year, placebo patients only increased from 20% to 23%. But then when you added voclosporin, 41% of patients were able to maintain a positive complete renal response. So this is very, very good study. This is a very, very good study, very, very good indication that voclosporin is actually doing something to maintain and preserve your kidney function. So in patients with lupus nephritis, this is a really, really great agent to potentially consider. In regards to the side effects between the two, between placebo and voclosporin, plus the standard of therapy, the serious adverse events were almost the same. They were both, 21%, which really showed that voclosporin had a lot of great therapeutic benefit in comparison to just placebo. Now, some key warnings for Lupkynis include increased risk of infection. This could be bacterial, fungal, viral, or opportunistic. Increased nephrotoxicity, so they can cause acute renal function or chronic kidney damage. But obviously, over time, we do plan to see a better renal response in that 20 to 52-week mark. Some neurotoxicities did develop in the study, and this can include seizures, delirium, headaches, mental status changes. Hyperkalemia, which is elevated potassium levels in your blood, were reported. And so certain diuretics, as well as certain blood pressure lowering agents, such as ACE inhibitors, may also increase the risk of hyperkalemia. So be watchful if you do have those agents and you're being prescribed Lupkynis. Some patients did get an irregular heartbeat, which came in the form of QT prolongation. So your doctor is going to monitor your electrolytes and run an ECG based on the results. And just like belimumab, it's very important to avoid live vaccines while you're on this therapy. This can include your MMR, measles, mumps, rubella, your polio vaccine, yellow fever, intranasal flu vaccines, and etc. And in addition to that, there is a fetal risk with Lupkynis, so you want to avoid pregnancy and breastfeeding while you are on this medication. Some other additional warnings include lymphoma, so cancer of the lymph nodes, as well as the cells that are part of your immune system can potentially occur. Skin cancer is also a potential risk and warning with this drug. So it's very important to monitor for any skin changes that you may have. You're going to want to avoid UV light, wear protective clothing, and use sunscreen with at least an SPF of 30 or above. Now, there is a very rare condition called pure red cell aphasia. And this is a calcineurin inhibitor general class risk. It's a very rare condition that usually affects adults. It's characterized by an absence of pure red cell or of your red blood cell precursors in the marrow and a low red blood cell count, showing signs of anemia. So if you do develop this, you would potentially experience fatigue, pale skin, dizziness, shortness of breath. And so this is one of the factors that your doctor will be watching some of your blood work to make sure that some of these things aren't happening. So it's very important to keep your appointments and keep those labs very scheduled. All right. Outside of that, calcium channel blockers for hypertension that you may want to dose adjust while you're on this medication include verapamil and diltiazem, because they are 3A4 inhibitors. And contraindication of Lupkynis is use of strong 3A4 inhibitors. This is an enzyme in your liver. And so basically when these inhibitors are present, these other drugs are present, they can potentially interact with Lupkynis and make it a little bit less effective. In addition to that, in regards to the safety and efficacy of cyclophosphamide with Lupkynis has not been studied. So you want to avoid cyclophosphamide and Lupkynis together because the interaction has not really been fully studied. So more to come on that as the data comes in. Some common side effects of this medication include hypertension. So again, this is one of the reasons why we want to avoid using this agent in patients who already have very high baseline blood pressures. Lupkynis may require dose adjustments if hypertension is treated with calcium channel blockers, like I mentioned previously. Another common side effect is going to be the classics, the diarrhea, headache, neurological symptoms, but also the anemia. The doctor will be wanting to double check your labs and make sure that red blood cell count is staying high to avoid that pure red cell aphasia. Cough is also another common side effect of this agent. There is an increased risk of UTIs, particularly in female patients. Abdominal pain is another common side effect. And unfortunately, hair loss. So definitely going to watch that hairline, of course. Some patients do develop dyspepsia and mouth ulcers while they're on this medication. And some patients do develop fatigue, tremors, and a decreased appetite. And now we're going to go on to another new agent. This was also approved in 2021 called Safnello. The generic is anifrolumab. This was FDA approved for adults with moderate to severe SLE who are receiving standard of therapy. The limitations of the use are the efficacy hasn't been really evaluated in patients with severe active lupus nephritis or severe active CNS or brain lupus. So the use of Safnello is not recommended in these cases of severe lupus nephritis and any kind of brain involvement with your lupus. And it's also not recommended for use with other biological agents. This could be other MABs and things like that. And in general, this medication works by blocking the interferons. These are basically cytokines that are elevated in many patients with lupus. They're just another marker of inflammation. And if anifrolumab's role or Safnello's role is still being defined, but there appears to be a particular benefit in patients with skin and joint involvement with their lupus. So definitely if you have more of a skin and joint involvement with your lupus, Safnello may be an agent that you may want to consider. It's starting to show some early data in regards to its efficacy and use. The dosing for this one, this is an IV therapy, and it's infused over 30 minutes every 4 weeks. Some warnings and side effects of Saphnelo. For warnings, you have the risk of hypersensitivity reactions, as well as potential anaphylaxis and angioedema, which is basically increased swelling of the face and throat. There is an increased risk of infection with this medication and an increased risk of cancer and other malignancies, similar to the other newer approved agents. Some common side effects of this medication include cough, as well as particular infections. In regards to infections, it seems to be particularly respiratory infections that are common with this drug. So definitely watch out if you already have a pre-existing, liver COPD, or any kind of respiratory pre-existing condition such as asthma. In addition to that, there are increased risks of influenza, tuberculosis, herpes zoster, which is shingles infections, and other severe infections can potentially occur with this medication. Patients should be up to date with all of their immunizations before you start Saphnelo therapy. And this is because live vaccines should not be used while you're giving this medication, because the medication can basically lower your immune system, making it possible for those live vaccines to become active infections. And with that, so that is pretty much the coverage of some of the 3 more recently approved agents. We're definitely looking out for any more new agents that are going to be on the pipeline. And to go over some of those therapies and some of those new therapies on the horizon, I'll hand it back to Ben.
Perfect. Thank you so much. All right. As Ocha mentioned, the hard truth and reality is that, lupus is a very difficult disease to diagnose and even harder to treat. But there are some medications in the pipeline that companies have been invested in and working on that we should be hopefully looking forward to within the next couple of years, several years or so. And distribution of clinical trials is, so the majority of the clinical trials have been in early and mid phase of development, which 68% of trials in phase 1 and 2 and 31.5% are in phase 3 and 4. So there are like a lot of medications that are being worked on in phase 2, but these are the ones that are more closely, to the finish line, so to speak. So first, we're going to start with dapirolizumab. It's a monoclonal antibody. The first one by Biogen. They just started their phase 3 trials in January 2023, and they are slated to have some updates in 2026. The way this medication works is it works on the cluster of differentiation, which is the CD40. So basically, they help to activate the antigen presenting cells and pretty much differentiate which antigens are supposed to be acted upon. And then we have, so that's in phase 3. This is going to be a sub-Q injection, and that's slated for 2026. Oh my gosh, I'm killing this. Oh, litifilimab, that's what it is. Sorry, litifilimab.
I can't wait for the brand names.
I know these drugs are getting out of hand. So the trial was initiated in October 2023. No end date up to date as of right now, although analysts have reported that they are shooting for 2025. And they work on the production of the pro-inflammatory molecules, so including the type 1 interferons. And so type 1 interferons they basically go from cell to cell and pretty much ring the alarm to let the body know that there is like a foreign object or foreign substance in the body and stimulates an immune response. That is going to be, once again, from Biogen as well. And that should be slated for 2025, hopefully. And then next we have obinutuzumab, and it's in phase 3 right now, and that's from Hoffman La Roche. That is going to be an IV medication. They are slated for the end of 2024, actually. So we're supposed to be hopefully hearing some results this year. It's a monoclonal antibody that binds to the CD20 protein on the surface of B cells. And essentially it kind of works to stimulate cell death that are potentially like the ones that are going out of whack. So the ones that are out of place and the ones that are overactive, it works on that, at that on that pathway. And then we have Rigerimod is performing right now. They're performing a dose range study to find the optimal dose for a once-a-month injection. So they pretty much, that product modulates the signaling of CD4 cells and also may interact with the T cell regulatory pathway. But like I said, at this rate, they are pretty much trying to figure out what is the optimal dose to be able to come to market with. And that is going to be from Pharma. They're in phase 3 right now, and it will be a sub-Q injection. And then ianalumab has been showing promising results in treating SLE in its phase 2 trial. It's looking to be administered through a monthly subcutaneous injection, and it actually employs the same mechanism of action as Benlysta. So it's been tested in at least 2 phase 3 studies, and the release of the top line data is expected in 2027. And then next we have deucravacitinib, and that is by BMS. It's in phase 3 right now. It's a JAK-STAT and tyrosine kinase inhibitor. It is an oral tablet, and it's looking to be releasing results in 2026 between January and January and then like the later half of 2026. They have seen great results in other immunotherapy areas, such as like psoriasis. It's seen really good traction in psoriasis, really good results. And insurances have been a little bit on the fence in terms of, covering this agent because it works so well, but it's expensive. But hopefully when, by the time it gets to, lupus, we'll have a little bit of a better solution for that. And then lastly, we have Telita-C-Cept, and that is from Rimgene Biosciences. It's in phase 3. It is also a sub-Q agent. And this one it's a novel recombinant fusion protein. And what they're doing is they're pretty much building off of the mechanism of action for Benlysta, as well as, adding in a few other, calcium modulators, and they work on a human transmembrane activator. And also they can really just kind of putting a few mechanism of actions together in order to kind of have like a better and a more targeted impact. So they have announced the phase 3, but they're not yet recruiting patients just yet. So we're looking forward to receiving some new news or some updated news about that in the near future. And then next, we're going to touch base on what are some different questions and myths for participating in clinical trials. I think one of the challenges is finding the right clinical trial for you. Even kind of overcoming some of the myths that or misinformation about clinical trials too. So we wanted to touch on a few before we wrap this session up. So these are some of the myths that I've heard, and some that have also been reported to other healthcare providers as well. So one myth is like, once I join a clinical trial, I cannot leave. This is absolutely false. If you join a clinical trial, once again, like it's a win-win situation in terms of like you're volunteering for the clinical trial, but at the same time, they are here for you. So if you would like to like leave a clinical trial at any time, literally the ball is in your court, and you are free to do so. It is not going to be, somewhere where, you're locked in a place and not able to leave. If you feel like you would like to exit, that is completely up to you. And you can join the next myth is you can join any trial that you would like to. That is also false. Trials have what's called inclusion and exclusion criteria. And so depending on your medical history, on your age, and some other factors such as that, they have a threshold for whether or not you can join the clinical trial. And once again, I think that would be going into the next myth, but it's something that you could talk to your doctor about to see like what are those inclusion and exclusion criteria. What are the things I need to look out for, kind of what, make sure that your interests align with the clinical trials, location, easiness to being able to show up to the clinical trial, like where they're located, and other things of that nature, like where what hospital they're being performed at, etc. If there was a perfect trial for me, my doctor would tell me about it. So that is also false. But we can have a discussion about it, right? Because doctors, they oftentimes they are busy, so they may not be able to align the perfect trial for you or be proactive about, bringing you a clinical trial. The patient's health is, or your patient health is really, it's a hand in hand and two-way street in terms of, a collaborative effort. So your doctors are here for you, and you also have to sometimes bring the trial and do the research to kind of bring it to their attention. So once again, you are your biggest advocate. I'm gonna say it again, you are your biggest advocate. Nobody knows your body like you. And so, by being able to do your research and becoming more knowledgeable and becoming, stronger in that, you are able to be a better advocate for yourself, and then be able to align with the perfect trial for you, or with, the best trial for you. Another one is clinical trials will not help me. Some may feel like, they're gonna give me, or they're gonna give the patient just a placebo, which is in some trials, they do, but in some trials they have an open label study so that you can know that you're getting treatment, and oftentimes as well, this is free medical treatment that you will be receiving with a clinical trial. They would also making sure they're, taking your vitals, taking any other health needs that you have. Like, it is their responsibility being in a clinical trial for them to serve you and help and make sure that, you are doing okay, and that you have somebody to talk to, and hold your head along the way. And then being a clinical trial is expensive. Oftentimes they'll actually pay you to be in a clinical trial. They will also compensate you for doing that. So it's not necessarily a area where you would have to pay, to participate, and most times they will actually, pay you and give you some form of compensation for participating. And then some questions that, I would like to go over, how am I protected in a clinical trial? So they do have a clinical dossier that, you will go over. They have a patient consent form so that you know exactly what you're getting into, like what medications you will be taking, or what medications that you are enrolling in a clinical trial for, rather. And so the patient has the utmost right. They're also, protected by the medical standards of practice currently. And let's see, how do I know I'm getting medication in a clinical trial and not a placebo? So as I mentioned before, some trials are set up so that it is a placebo trial, so that you really won't know if it's a double blinded. That means, you won't know, and the physician administering, or the person administering, the medical professional administering the drug, would also not know. But in an open label trial, an open label like extension trial, you would be getting, the actual drug in that is being hypothesized. And then trials make me feel uncomfortable. What should I do? So there's a few avenues that you could take whenever you are thinking about enrolling in a clinical trial, right? You could definitely talk to your doctor about it. You can talk to your family members, your support group, to see if this is something that you will be interested in. And also, lupus is a community, so you can definitely reach out to other members of the community that have already participated in clinical trials and kind of get their take on it, and see, what are some concerns that they had, and what are some ways that they navigated that process as well. So yeah, I just wanted to go over a few things, a few questions and myths, and if there's any other further questions or further interest in this, we can definitely take that feedback and take that into consideration moving forward in our future elephant C medication reviews. Thank you for joining.
Great, thank you so much, Benjamin and Osa. Now we're going to open up the Q&A session. I noticed that somebody had their hand up during the presentation, and I checked to see if they had a question. So if you have a question, please type it into the Q&A chat right now. Let me see if I could find them. I'm not sure if I could. Would you guys mind if I tried to allow them to talk?
Yeah, that's fine.
Let me give that a shot. London, you had your hand up, and let me see if you'd like to talk. I have unmuted you, London, or you are muted. So let's see. If you unmute yourself, you might be able to ask a question. It might be too long to type. So London, are you there? I can't hear you. You look like you're still muted. I'll go ahead and ask one of the questions that came in while you were presenting. In
It looks like London
Lu-
sent a message. It looks
Oh,
like she
okay.
said, or they said, I'm
Great.
currently walking with a company called I Choose Life, working with a company called I Choose Life.
Okay. All right. Well, I'm not sure. I don't know what that means, but thank you.
I'm sorry.
Um,
Can you hear me now?
I
Yeah,
can,
we
yes.
can.
Yes.
Okay, sorry about that. I'm
That's okay.
currently I don't know a huge amount about your company, but I did sit in with another webinar where they're talking to lupus patients and so forth, and a doctor was actually present and was speaking about the new medications that are being discovered. And I'm actually working with a company. I was trying to put working, but it said walking. Sorry about that. But I'm currently working with a company called I Choose Life, and we're trying to recruit lupus patients, actually for BIPOC patients. And I wanted to know you guys is it's for clinical trials that we're running all around the United States right now. So I was asking, what do you think is the best way to kind of get more people to join and feel comfortable about clinical trials?
Yes.
That's it.
No, go ahead.
No, you go ahead.
Got you. So I think we have to kind of combat the stigmatisms that do come with that. I think that potentially having more community events where we're bringing people in and getting people comfortable with talking to physicians, talking to healthcare providers in a safe space and talking to them about their health definitely could be a good thing. I also ran across a company called CliniSpan, and they do like social media campaigns to kind of promote clinical trial participation, to kind of let people know, like, no, it's not necessarily, it's not like to say like this is cool to participate, but like kind of just breaking down those uncomfortability walls about it. I think that initially when you say clinical trial, I think there's still a lot of stigmatism around that. And so kind of being able to hear from other patients that have already participated in clinical trials and hear their thoughts about it and see like how they navigate it, I think it will be a good way to kind of start getting involved and really like increasing the amount of participation in clinical trials. And then also, I do work with another company called Sightline, and they actually work with organizations such as you all as well to kind of find sites and find patients via like de-identified health information, to try to see like what on paper like would be potentially like some good target areas to go out and do outreach. And then they kind of work with organizations such as yourself to kind of deploy those resources into those communities and kind of increase the advocacy in those areas.
Okay,
And
thank you. I appreciate it.
as for the Lupus Foundation, we always are working with doctors when they talk about different clinical trials, and we are happy to list them on our website so that lupus patients can get information via that course for free as well.
I love that. Okay, thank you so much.
Sure. Our next question is, have you heard anything about naltrexone being FDA approved for treatment of lupus? Some research has some success in treating lupus. Is it true?
Yeah, that's a really great question. I saw the question and I just started doing some literature research. It looks like naltrexone is currently being kind of investigated for rheumatic diseases, not specifically lupus. And it looks like it has some potential analgesic and anti-inflammatory potential effects. And so it's still very early in its investigations. There's been a few case studies, a few like literature searches, a few open label studies. So I definitely would say like there's a lot of different drugs that have anti-inflammatory effects that can potentially be investigated. It looks like it is just starting, but I wouldn't necessarily go and say, oh yeah, naltrexone is used for lupus. Be very careful with that. We still don't have a lot of information and we don't have a lot of direct clinical trials yet on that. But really, really great question. It's definitely something for the researchers to potentially study if it does have that potential effect. But just based on the mechanism, I mean, opioid receptors and et cetera, not really a lot of potential potency, I would say, at least clinically, from what we understand so far in the literature. But definitely something for the researchers to investigate. So we'll definitely take a look if there is anything prominent about that. But as of right now, we wouldn't really make that recommendation or potential use for it yet. Great question.
Okay, great, thank you. So could you stop sharing your screen as well?
Yeah, sure.
Sorry, thanks. Then they can see all three of us. A question came in while you were chatting about Benlestra. I can't remember how to pronounce that. If the question was, if somebody had previously suffered with depression or psychotic events, should they stay away from taking it?
Yeah, that's a really great question. It really depends on the benefits and potential risks. And it's definitely something that the doctors would probably have to weigh with the patient. It really depends on the severity, like if you've actually had a prior episode. It will also depend on your current status, how stable you are with your other potential therapies for your depression. So it really would be something that's, you can't just blanket say it's probably okay. It's really going to depend on the prior history, talking with your physician about your current therapy for lupus. I wouldn't say that's something that they would rule out, but it's something that they would be just cautious of in starting. And they would really want to monitor and make sure you have other things on board, such as a therapist, counselors, a good support system before they may want to start you on that medication.
Okay, so definitely something you'd want to talk to your doctor about before you went on to. Yeah, okay. Another message that came in was, and this may be out of your scope, not sure, but is there a particular kind of HRT, hormone replacement therapy, that works best for lupus patients?
Yeah, that's a really great question. I don't know if there's actually any literature on that. Let me take a quick look.
And while Os is doing that, remember you guys type in your questions, or if you have a very long question, you don't feel comfortable typing it in, raise your hand and I'll let you speak. But this is a great opportunity to ask questions of pharmacists that you don't normally get the chance to. And if you type it in, I'm not going to say your name, so it's anonymous from that standpoint too.
Yeah, so just based on this is again very brief reading. It's a really, really great question in regards to birth control and potential lupus. Because of the increased pro-inflammation of lupus generally in the body, there is a risk of thromboembolic events, particularly with estrogen containing birth controls. So I think the risk would definitely be in more estrogen progestin hormone contraceptives. We wouldn't necessarily rule them out because they obviously have a particular use. It would really just depend on your actual risk of thrombosis, how young you are, how old you are, other potential factors. But I wouldn't say that we're ready to roll out all estrogen containing birth controls in all patients. It's really just going to depend on the patient and their prior history and current risk of thrombosis. But definitely I need to look more into it, but that's a really great question. We may do as another additional follow-up for the next presentation.
Okay, great. All right, we'll give it another minute to see if any more questions might come in. Doesn't seem like anything is coming. Well, we really appreciate your time and all of your knowledge that you've been passing on today. Yep, it looks like we are not getting any more questions. So I will, oh, I know, one did come in. I'm sorry that this came in after another health conference, but I thought it was a good one for you guys. And is hydrocortisone a medication for skin rash or butterfly rash? I think what they meant was, could it be used as a medication for the butterfly rash?
Yeah. Yeah, let me take a look. That butterfly rash is a very specific side effect for or specific manifestation of lupus. But let me take a look.
Okay.
From my understanding, I don't think it'll be used on the face. necessarily, and that would be the only thing, because the butterfly
Mhm.
rash is typically like on the face. So,
Mhm.
also you can let me know how you feel as well.
Yeah, that one's gonna take a little bit of a deeper dive for sure,
Okay,
especially because it involves actual treatment. So
right,
we can probably go over that in additional supplement for the next
sure.
presentation, how to deal
I
with the
had
butterfly rash, things like that.
Sure. Two other questions that came in. Is low vitamin D a symptom of lupus that you're aware of?
Low vitamin D.
Mhm. These are some good questions today, huh?
Yeah, these are some
Stumping the
great questions.
pharmacist.
I don't remember if from our initial presentation, Ben, if that was one of the factors for lupus was low vitamin D.
I mean, I think
I,
it may be something that kind of goes hand in hand, because like the sun exposure can also have like make the skin sensitive to sunlight. And so because of that, you also might have a little bit of vitamin D deficiency as well. And due to the risk of like skin rashes and rare flare-ups, just kind of triggered by the sunlight. So sometimes they go hand in hand. And then some other evidence I'm reading, it suggests that vitamin D deficiency may play a role in development of like worsening in autoimmune diseases such as lupus. So because it does play a significant role in the immune system regulation. So yeah, they kind of can go hand in hand.
Okay. Great. Well, now we've got a couple questions to add to your next time. um, great. Well, thank you so much for the great questions that were supplied. And thank you, Dr. Hinton and Dr. Edogun, for this great presentation. I hope everyone learned something new today. I know I did. If you want to rewatch this health conference or share it with your friends, it will be on